Hi. Hopefully I've given it the appropriate amount of time. My name's Keith Jones. I am the Surgical Director of the ICP, and I'd like to welcome you to this webinar about the new curriculum update for the changes that are going to take place when we go live in the beginning of August. It's directed for you as surgical trainees. My panel co-members this evening are John Lund, who is the chair of the JCST. So welcome and thank you, John, for your time, and Sophie Lewis, who is your Assets Director of Education. So Sophie, thank you very much indeed for coming this evening. I know that you're going to grill us on anything that we've not discussed or presented a little later. So hopefully we're moving towards to go to John, your slides.
Right, well, thanks very much, Keith. I'm just going to go through the background to the curriculum and go through it quite quickly, because I think what we want to do tonight is have lots of time for Q&A. It's not long to go till the new curriculum comes in, and I think it's really important that we iron out any problems or misunderstandings or just questions that people have before the 4th of August in 21 days' time when it starts. So new curriculum update, next slide, please. So in this talk, what I'm going to do is talk about why we're going to change to new curriculum, how we're going to change to new curriculum, what we're going to change, and when we're going to change. Next slide, please. So why change? So the main reasons are these documents that came out in 2017, these three things, two from the GMC and one from the kind of distillation of the shape of training report by David Greenaway. The first, Excellence by Design, is a document that tells us how all new medical curricula should be shaped. Generic Professional Capabilities Framework contains all those things that any doctor needs to be able to do to be a doctor before they're a surgeon or an oncologist or a paediatrician or a GP. And then the Shape of Training report from the UK Shape of Training Steering Group laid out some really high level targets for curriculums to satisfy before they would be approved. Next slide, please. So the new curriculum standards laid out in Excellence by Design, what they wanted to do was to move away from that sort of over granularity of curricula and the work-based assessments, where you get lots and lots of tiny assessments, but it doesn't really give you a proper picture of how you're doing. And you're too close to the picture. You need to be able to stand back to see things more clearly. And so what the Excellence by Design required all curricula to do was describe sort of fewer and high-level generic outcomes that were shared between all specialties within surgery. And also he wanted us to put the generic professional capabilities, those things that all doctors need to be able to do to be good doctors, right at the center of all curricula. So it runs through them, through the curriculum and the assessment process, like letters through a stick of rock. Next slide, please. So the generic professional capabilities, you might not have seen this, and if you haven't, I would just suggest that you Google it and just have a look for yourself at the generic professional capabilities. Just a quick skim through the executive summary and the first chapter of it. Really, what they are lots of capabilities that arose from the GMC looking at their fitness to practice hearings, and they noticed that there were recurring themes, things that doctors didn't get right time and time again, that meant that they were up before the fitness to practice hearing and could lead to disciplinary action, suspension, or even being struck off. So what they wanted to do, probably quite sensibly, was to reinforce all those recurring problems in training to make sure that consultants and GPs all arrived at independent practice much more ready to face modern healthcare. And then they expanded a bit on that to arrive at 220 descriptors, probably slightly too many and slightly too detailed. But when you have a look through these, organized into those 9 big areas that you can see on the diagram on the right there, you'll recognize that most of them are really those things that not only make you a good doctor, but probably just a decent human being, and a lot about integrity and being able to do the job properly and about interpersonal relations. And what they wanted to do was to make sure that in all curricula and in all assessment, that this was equal to knowledge and skills in terms of how important it was in the curriculum. Next slide, please. Then the Shape of Training Implementation Group had a reasonably long report, but comes down to these 5 major principles that need to be met before any curriculum in surgery or any other specialty can start to be developed and move forward further. And of course, the first one is really where you would start with any curriculum. Really, it needs to take account of and describe how the curriculum will meet the needs of patients and the service providers. So, in essence, be fit for purpose. And I think that not necessarily surgical curriculums, but some other curricula had kind of been designed by the doctors, and the service have to fit around that rather than the curriculum fit around what the service needs. Also, it requires that in any specialty that someone who's a new CCT holder will be able to participate in the acute unselected take, and this is the case for all specialties in surgery. Not much surgery happens in the community, but so we didn't have to consider that too much. And also, the new curriculum had to support more flexible approach to training. And this doesn't necessarily mean less than full-time training. It means about transferring skills from one specialty to another if you find that that specialty wasn't for you halfway through training. So you don't have to go all the way to the bottom of the new specialty if you transfer specialties, but you can start some way up the ladder by taking across those skills that you've acquired already. And then the last thing he wanted to do was describe the role of credentialing. Now, we really haven't moved on very far in the 4 or 5 years we've been talking about credentialing, and the GMC still haven't, in their words, developed their thinking fully on this. So we're still waiting for that. Okay, next slide, please. So how has the change happened? Just sort of give you a bit of an insight into how curricula develop. And it's a very, very long process. So I started with Gareth Griffiths talking and thinking about this in 2017, and we developed a generic purpose statement for all surgical curriculum. The purpose statement is that thing that it's a sort of a one-sided document that says what the curriculum is for, what the output of that curriculum is. So in urology, in general surgery, in neurosurgery, in any specialty. And it describes various items that will describe what the output of the curriculum was and how that will fit into the service. Once that had been approved by the curriculum oversight group, we fed it back to the specialty advisory committee in each specialty to modify it to be appropriate for that particular specialty. And then curriculum oversight group reviewed all those and approved them in the first stage of approval of curriculum. Then we had to go away again, this is 2018-19, and then develop the full curriculum itself, which includes assessment and how to learn and where to learn, and the index procedures and critical conditions, etc., and develop that, and again put it to each individual SAC so that they can make it specialty specific. And then we send it to the second approval stage, the curriculum approval group, which consists again of the GMC, the 4 statutory education bodies, so HE and their 4 nation equivalents, the 4 departments of health around the UK, and various other stakeholders such as NHS employers, etc. And all the way along here, from start to finish, we have involved stakeholders, not least of which, of course, are trainees through various groups, especially ASIT and BOTA, the main trainee representative groups, but also employers, trainers, directors of medical education, the GMC, lay people, patient groups, etc., etc. So all the way along, there's been lots of consultation and modification of the curricula in response to that consultation to make it really ready for what the service needs. The curriculum advisory group, the CAD, gave the second round of approval in late 2019, but of course we were going to introduce it in August 2020, and then you'll know what happened in March 2020, and so we decided that we would delay the implementation of the curricula for a year. We thought it was very unlikely that anyone was going to take any notice of a new curriculum coming and have the time to do that because of all the other things that were happening. So here we are a year later. COVID's still going on, but we seem to have come to terms with it more or less and accommodate it into what we're doing with some remaining challenges. But then now's the time for the curriculum to come in on August the 4th this year in the UK. Next slide, please. So what are the major changes? Well, Keith's going to talk a lot more about some of this, but the main change is that all curricula will be outcomes based. That means that you can finish training when you are ready to be a day one consultant. It's all within the bounds of the gold guide. So there is a maximum indicative time for training, beyond which you will need extension through the usual ARCP processes. But you can finish training very, very quickly and safely if you develop the skills required to be a day one consultant. Training is going to be divided into phases. The main thing is that phase one will be core training, 2 years, indicative 2 years of core training, and then each specialty will have a phase two where in 3 or 4 years, depending on the specialty, indicative time, where trainees will develop the general skills, the skills and the generality of that specialty. At the end of phase two, trainees will be eligible to apply for the JCIE FRCS exam in their specialty and move into phase three. Phase three is an indicative time of 2 years in all specialties apart from neurosurgery, and it's where you develop the technical skills to the final technical skills in your specialty, and also develop a special interest in your specialty where those are described in your syllabus. We also will develop 5 main areas shared between surgical specialties of the job, the working week, developed into 5 areas to make assessing whether your progress towards day one consultant much easier. And these are known as capabilities in practice. And you'll have seen those described, and Keith, I'm sure, will talk about those soon. And then also built into the curriculum are the generic professional capabilities, running through like letters through a stick of rock, as I said earlier, and be assessed in the multiple consultant report, which will be the new major assessment tool of all surgical curriculars. And also, very importantly, the multiple consultant report tool will also be used by trainees to assess their own progress in each of the capabilities in practice and generic professional capabilities towards a day one consultant, which will really drive forward insight into your own learning and training needs and really help a productive learning agreement, which again, I hope Keith will be saying a few words about after me. The good news is that to make way for the multiple consultant report and to move away from that granularity that the GMC want us to avoid, is that work-based assessments are now relegated in importance, and now we're only required for the critical conditions and the index procedures that are described in your particular curriculum. So no more mandatory numbers, arbitrary numbers of WBAs per year of 40 or 60 or 80, depending on where we are in the country, to the great relief, I think, of both trainees and trainers. And hopefully with the MCR, we're going to move from where we are now to really have some very valuable detailed feedback on how to get better in the next 3 to 6 months of training each time you have an MCR. There are some major specialty specific changes, and I thoroughly recommend that you all have a look at your own specialty curriculum before August just to see what's happening in those. But there'll be update of the syllabus. So we've managed to rationalize lots of the syllabus and throw away those things that are no longer in date. So make it fit for purpose for the next 3 to 5 years before there's a next curriculum update. Cardiothoracic surgery, we're moving from 8 years to 7 years in indicative duration, and there's quite a lot of changes to the special interests in general surgery, the chief one being the incorporation of the oncoplastic TIG and the trauma TIG into the pre-CCT curriculum, and the development of oncoplastic breast as a special interest and trauma as a special interest in general surgery, and the real focus of emergency general surgery for all trainees, apart from those following oncoplastic breast and multi-organ transplantation in general surgery. Next slide, please. So awfully soon, when are we going to change? In case you haven't noticed, where we wanted to be about now is people just sick of hearing about new curriculum. So hopefully that's where we are. But it's going to change in 21 days on Wednesday, the 4th of August, 2021. And the curriculum will be followed from then. Next slide, please. Keith's going to talk a lot more about the details, but for anyone who wants to find out more, and I really encourage you all to do so, is if you go to iscp.ac.uk on the homepage, click on the banner at the top that says surgical curriculum, it will take you to a page where everything you need to know about the new curriculum is described. And also, if you search for JCST ISCP on YouTube, you'll find lots of helpful and informative videos about the changes and easy to use help guides about the new arrangements in the new curriculum. So that's all from me. I'll hand over to Keith, and then we'll take lots and lots of questions, I hope, and clarify a lot of issues for you at the end of Keith's talk. Thanks very much, Keith.
Excellent, John. Thank you very much indeed. So hopefully seamlessly, I will go to show again the front page of the ISCP. If you click on the curriculum, it will take you to the curriculum page. So that's a site, and hopefully this talk is going to help to debunk some of the myth that may have been talked about in relation to the curriculum. There are very supportive and helpful videos that will tell you how you're going to undertake a self-assessment. For example, give you introduction to the general professional capabilities and the capabilities in practice. We've got pop-up videos for the MCR as well, for the learning agreement, and all of that information is available from that first page on the ISCP. Hopefully you've already undertaken to click on this trial MCR when you're undertaking a trial self-assessment, and I really would recommend that you do that, not just from a point of understanding, but as I'll come to, it acts as a fantastic gap analysis in relation to what you may have lost from COVID and how you might catch up. In essence, what are the key changes for you as trainees? Well, it comes on board the 4th of August, which will be next time job change. As John has mentioned, it's going to be outcomes based. The outcome for everyone is the ability to act as a day one consultant in their own specialty. You can progress at your own rate. That means if you can show competencies and move quicker than you are able to. The timeline is indicative. The certification requirements no longer give a time stipulation. It's all about the acquisition of competence and being able to show that. Those competencies are the levels of supervision that you will require will be assessed through the multiple consultant report, and you will have an opinion on that because you'll do it all through self-assessment as well. So the key for the MCR is the professional judgment of your supervisors, and by you undertaking the self-assessment, you are going to be developing that professional judgment as well based on yourself. The capabilities in practice are the surgical specific outcomes that are indicative of the end point of training, which is why the supervision level 4 that you have to achieve is the ability to act as a day one consultant. The generic professional capabilities have equal weight. They're very important professional type skills, as John has alluded to. So they do carry equal weight, but they are assessed as being appropriate for phase. So are you appropriate for your phase of training at that time? And therefore, as a point of assessment, they can be moved through very quickly if indeed you are appropriate for phase. The supervision levels, as I say, are set at the level of a day one consultant. Through your self-assessment, which is, as I say, part of the MCR, it will be compared to the MCR when you have your feedback sessions. You'll be learning to assess yourself against that point, and you'll have a much better idea about how you are progressing through the syllabus. The learning agreement will take the feedback that you get from the MCR and therefore be able to focus on the developmental requirements and then create outcomes that you need to work towards. To answer a question that comes many times, the work-based assessments have been reduced. There is no longer you have to do X amount this year. The work-based assessments are just focused against the critical conditions and the index procedures within your respective syllabus. The training, as I say, is fixed into 3 phases. Sorry, I flicked too quickly. So those phases are in essence phase 1 is core training. There's a little bit of crossover in relation to cardiothoracics when it goes to run through, because phase 1 includes what would have been ST3 and ST4. But core surgical training is essentially phase 1, which would be indicative for the majority of people 2 years. You go into phase 2, which would be the start of higher surgical training. It's listed as being indicative for 4 years. There's some variation between some specialties. Indicative means that if you achieve those competencies at an earlier level, then you can move through, and therefore you'll be able to undertake the exam at an earlier stage. Phase 3 is where you'll get all your capabilities in practice up to the level of a day 1 consultant, and it's where a lot of the technical skills acquisition is going to be undertaken. So a lot of the PBAs that exist for index procedures may well be undertaken during that phase 3. Some specialties, it's important to look through the curriculum that you can access from the front page of the ISCP, but some of the curricula have got decided to go for PBAs that show progression, so outcomes 2 and 3, as well as outcome 4, to show how you've progressed to the endpoint of competence in a particular technical skill. So hopefully you agree that with the enhancement of the graphics, the ISCP works really nicely at present. So you will be taken through when setting up your learning agreement. You'll be asked, are you sure that you want to be transferring to the new curriculum? And at which point, when you're setting up your learning agreement for your new placement, which will be the time of change, you'll click yes. You want to go to the new 2021 curriculum. I'll cover the caveats of who would say no to that. So who changes? Well, upon entry into core surgical training or specialty training, you will start on the new curriculum. If you are moving between a year, so in August, if you go from ST3 to ST4, you're doing that in October. When you're setting up that learning agreement, that is when you'll change. What if I change in February? You may say, well, you can wait until February to change between changing through the years. But actually, if you're setting up a new learning agreement, you're halfway through a training year, you could change onto the new curriculum. The exceptions for people that don't need to change are those people that have a short period of time left on an old curriculum. So in decoupled training, if you're at CT2, you just have a year to go, so you would complete that old curriculum before changing to the new curriculum when you go into higher surgical training. The same applies for those people that are entering their last year of surgical training. However, they may want to have a conversation with your training program director if you've identified that you feel that you can show that the competencies more easily on the new curriculum. It may be appropriate to train. For the less than full-time trainees, you would change at the time when you transition to the next training level, so inclusive of the pro rata time. However, if you are able to show the competencies, you don't need to wait until you've completed that timeline. You could undertake the MCR, which would show that competence, and change to the next level sooner, thereby speeding your way through training, provided obviously that you are able to show the competencies. The CSER group can be evaluated against the new or the old curriculum. They just have to choose when they start. But like all trainees, the CSER group must have completed their transition by the 2nd of August in 2 years' time, so 2023. So they may feel now on choosing that they'd want to go onto the new curriculum. Well, I've got some advice about pre-transition. I would ensure that all of your previous assessments are signed off, so you don't go to cross curriculum to go back to them. I would personally undertake a detailed self-assessment and use it as a gap analysis. So spend a lot of time going through the self-assessment, give yourself a baseline and also a gap analysis of what COVID-induced gaps have been occurred, and then you can work out how you're going to catch up. Create a summary of all the work-based assessments you've undertaken prior to August 2020. Why then? Because any WBAs undertaken since that time will be on the WAs for certification page. None of those WBAs that you've undertaken before will be lost. Don't worry about that. But if you've got them all collated in one place, it makes it easier. It's what you do now. So don't forget to do that, because then you can utilize those at your ARCPs or at your next objective setting meeting. Definitely at the point of transition, have a clear idea of the objectives to include how you catch up from time lost from COVID. So the learning agreement has changed. It's been updated. It's really interactive between the MCR and your self-assessments. You'll be able to walk through it easily. There's lots of these timelines. The selection when you set it up, your learning agreement, selecting your CSs and lead CSs, that will be ratified at your objective setting meeting, and then would allow the MCR and the self-assessment to be undertaken. The learning agreement has, when you're setting it up and when you're going through it with your AES, has the ability for you to look and compare and contrast that you have done previously. So your MCR will move into your next placement as for your self-assessment, and that will form the discussion for your objective setting. The one time that doesn't occur is when you first do it, because it won't have been there from previously, which is why it's a great idea to have done a trial self-assessment and ask your supervisors to have previously done a trial MCR. And if you have got saved copies of those, you can take those and show them face to face with your educational supervisor, much in the way that the ISCP will do for you in the future. The assessment system, I just wanted to highlight this because it still has the procedure-based assessments and the case-based discussions, but to tell you again that there is now no longer an annual number of those that have to be achieved. They are focused against critical conditions and index procedures that have to be achieved for certification at the end of training. So you should do them at the appropriate times, not be just forced to tick box through X number a year. The biggest change is the MCR and the MCS, the self-assessment within the assessment system. I mentioned this WBAs for certification. This is an example of the vascular one to show how people would be progressing through related to the critical conditions. You see, we'll come back to the timeline for the learning agreement. When you'd come, this was how it would look when you had undertaken your self-assessment, and that self-assessment is the prompt. The MCR is not the responsibility of the trainees to drive. It's the lead clinical supervisor that you will have nominated. Once that MCR has undertaken and the AES has signed it off, you as a trainee would have vision of that, be able to compare it to your self-assessment. Think about those things that you would want to discuss when you have the face-to-face feedback session with your lead clinical supervisor, and then you can come up with the developmental aspects, so you can take those to your midpoint developmental meeting with your AES as you progress through your learning agreement and your placement. So the MCR setup, you nominate a lead clinical supervisor from your list of clinical supervisors. You do that, ratify that at your objective setting meeting. You could change the lead CS if you needed to. The lead CS, as I say, lead clinical supervisor, they organise the MCR. It is not your responsibility. We've done lots of training and interaction with our consultant colleagues. It may take place on Teams, face-to-face, departmental meetings, local faculty groups or education groups. But certainly that face-to-face meeting, the supervisors will take place, and in a particular forum, they'll produce a joint report. They'll have a 2-week period when they'll feedback between themselves and the AES, and then it'll be closed and presented to yourselves. You will have a dedicated feedback session, and that feedback we think is one of the major advances, because you'll be then to really focus in on the developmental issues and work out a plan. So this is what the MCR looks like in the present pages, with the trial watermark in the background, but when it goes live, that won't be present. The graphics are very helpful and swift. If you click on appropriate for phase, then you can move through that GPC page very quickly. Likewise, if you choose to utilize the descriptors within any of the 9 domains of the GPCs, that those are easy to find, and you'll get very used to the positions about where they are, and to be able to work through. You can do this and will do this as well within your self-assessment. So let's talk about self-assessment. It is the same as the MCR. We would encourage you to do it before the midpoint learning agreement, and definitely you need to do it before the final learning agreement meeting. How are you going to do it? Well, you're going to utilize the skills of reflection. You're going to honestly appraise yourself. You look at your own level of competence in both in a clinical and a professional capacity, and then be able to assess what your strengths and weaknesses are, identify your needs. There is an online guide available, and if you have any questions, you're always welcome to come to one of my Ask Keith sessions that we run on Teams. So the trial self-assessment, as I say, it looks the same as the MCR. There is still the 9 GPCs to be worked through, and then through to the capabilities in practice. So you're assessing yourself about the management, the outpatient clinic, the inpatient and ward rounds, the emergency take, the management of the operating list, that's globally the whole list, and the management of multidisciplinary team working. As you go through the self-assessment, you can click on each of the capabilities in practice. You'll get the descriptors. If you're not scoring yourself as level 4, and clearly you won't do that until you're up into phase 3, then you would show which areas you think may need some development, but you can also represent which areas you think you do really well, and that will be interesting to compare those to the feedback you get from the MCR. What are the benefits to you for self-assessments? Well, those skills that you utilize, reflection, honesty, will be developed. We think it will be good for your confidence to know how you've been developing over time. You get a real understanding about where you are, and that really helps you to develop your own training needs. You can ask other people, you can involve their advice. You can certainly look back and see how you've progressed and compare against previous MCRs. And your self-assessment is the basis of the discussion with the lead clinical supervisor, and to compare it and contrast it with the MCR report. So just mention briefly about the supervision levels. Level 4 is where you're at, aiming, day 1 consultant, but it builds up from just your observing to direct supervision to the trainer there all the time, part of the time, and then indirect supervision. Remember, with these levels, you can show excellence level 5. We've got this throughout lots of our talks. It's the helix that show through the MCR activities from setup, a 2-week wait and feedback, the AS closure, and then the important feedback meeting with yourselves. And then you can take the outcomes from that to your learning agreement meeting with your AES. It's a cycle of event. What the MCR feedback to you will give you is really comprehensive feedback that's relevant just to you. It'll done on a regular basis. It's based on a consensus, so a group of professional judgments. If you do it in the midpoint, it allows for your progression in the placement. It'll give you an action plan for the future. It's definitely designed to give you support. It really does take into account your learning style. Very important for you to identify your best learning style as early as possible. Looking back at your MCR, show your progression through history, and any of the comments can be moderated and supported by your AES. They're able to link in aspects of your portfolio to show the evidence. And as I say, the MCR will be discussed and compared to your opinion, as well as where you sit. So I just go over back again. I listed what I saw the MCR from the benefit from the overall benefits, and essentially it's through the board. Bottom line is you can develop and demonstrate excellence. You get feedback. It's based on professional judgment, and there's clear even weighting between the GPCs and the CIPs, all based towards that higher level outcome of being to level 4 day 1 consultant. Each of the specialties will have critical progression points related to the CIP outcomes, and it's important that you know those. Now, if you want to read one thing, read Appendix 4 of your respective curriculum. If you're doing a trial MCR, please remember to save the print copy, and then when you save the PDF, because you can upload that into other evidence in your ISCP and take it to your objective setting meeting when you transition. Makes it much easier for yourself. And if you have any questions, then do feel free to come drop into one of my Ask Keith sessions. So hopefully I have debunked some of the myths that there may be, and we, John and I, are now open to Sophie asking us any questions you want about the new curriculum.
Thank you, Keith, and thank you, John, for two very informative presentations. I'm just going to ask some questions that have come up through the chat. So it's really interesting to hear that the WBAs now don't have a finite number that you need to achieve within your training. One question that has come up, though, is that if you have WBAs that are in your previous years, do they still count towards your training within the new curriculum?
Yes.
Yeah, so if you know, you can't unlearn things, you can't unexperience things. So it's WBAs are feedback, so you've got lots of feedback from the WBA, and if you've got a level, a curriculum outcome level in an index procedure or critical condition, yes, of course that will be carried forward. You've got that in the bag, as it were. You've achieved that level, and so that can still count towards CCT. So we're not wiping out any previous experience.
And I was just going to add as well, so obviously you have your index procedures, particularly more relevant to your PBAs. How would you advise trainees then to use their CBDs or mini KEXs to sort of target those critical index procedures or clinical scenarios that they are expected to come into contact with?
The CBDs and KEXs should be utilised for the critical conditions. You'll see I showed you a vascular slide. Vascular just has 3 critical conditions. The other end of the spectrum is paediatric surgery, which has quite a lot, a much broader spread. You can still utilise CBDs and KEXs for non-critical conditions, so non-mandated work-based assessments. And the way you might do that is from the MCR. It may come out that you agree that there are certain knowledge aspects or technical skills or the assessment of a certain condition that you would need to develop, and therefore you might decide to show that you've done that and how your development has progressed by undertaking a CBD on a KEX on that particular topic. So you'd use them in a very focused way. There no longer is an idea that you just do it for doing its sake, which I know some of you feel had been the case previously.
Do you have any fear, though, if there isn't a set number, that trainees won't cooperate and carry out the WBAs, and how will trainers and the educational supervisors look into that, and what advice, I guess, for them in terms of encouraging trainees to become more involved in completing work-based assessments?
Well, so I think everyone on the call is a grown-up. So if you want some feedback on how you're developing in particular areas, then ask for feedback. And if you want to formalize that and record it, then do it through a WBA. What's going to, hopefully we'll have to make anybody do anything, because, I think hopefully people will see the benefit of these things. But, the bottom line is you won't get CCT unless you have achieved the curriculum requirements, which will be those WBAs in the index procedure and critical conditions. Anything else is for your own benefit as feedback, and you can use it as feedback or not along the way, but you will need to do those by the end to just underpin the supervision level awards in each of the CIPs, because those index procedure and critical conditions are the absolute central things of most specialties that really need to be further evidence to make sure that someone's safe to be a day one consultant.
Just moving on then to the MCR, it was really useful to hear that it's sort of down to the educational supervisor or clinical supervisor to organise these meetings rather than it being the responsibility of the trainee. And I think that's something that a lot of trainees have a lot of anxiety about in terms of where that responsibility lies. If a trainee does find themselves in that position whereby they're struggling, what advice would you give to them if struggling to organise that meeting? What advice would you give to them, and who should they be contacting?
I mean, say the bottom line is they don't have to organise the meeting, so that there won't be the case of them struggling to organise it. The best thing that you as trainees can do at the point when you've had your objective setting, when it's the point where you think the MCR should be taking place, is to do your self-assessment. And your self-assessment is there and ready to be discussed with the MCR. That will prompt and the lead clinical supervisor and the clinical supervisors to undertake and to have their meeting. The AES is not going to sign off on an MCR and therefore not going to do the objective, the midpoint review until they have signed off. That's the other way of doing it. So they'll be driven by the AES and the AES will be driven by the TPDs.
So any problem you're having with anything in your training, there's a recognised way to escalate this. So you speak to the person who should be doing it for you. No joy there, speak to your AES. No joy there, speak to the TPD. No joy there, speak to the head of school. And so, you know, if they're obviously in the whole of the UK and Ireland, there will be some times where this doesn't happen and people, you know, trainers don't engage. And so that's any problem needs to follow that escalation policy. And hopefully we'll get nowhere near even the TPD. The AES will sort it out for you. Speak to one of his or her colleagues and say, come on, let's do this.
Absolutely. And one of the other
we'd
sort of
hopefully
questions...
reassure you, Sophie, to let you know. Well, I was going to say, so we'd reassure you to let you know that we have written as well to all the trust chief executives and medical directors and requesting that all of their trainers are aware and given the appropriate time to get used to the change, and it's ready. So it will come as no surprise to the sort of higher levels of management within trusts either, and they will be supporting it. We've John's done a recent webinar with all the DMEs as well. And we've been doing constant webinars with all your levels of trainers, so they do know about it and they will be happy to undertake it.
That's really good news to hear. I'm sorry if you've covered it. Is it once a year you want an MCR completed, or is it per rotation or every 6 months? What would you advise to trainees?
So it should be, so there's no point getting to the end of a placement and someone saying, hey, John, you were rubbish. Like, tell me that halfway through and then tell me how I can get better. So what we'd really like people to do is to have an MCR at the midpoint and self-assessment at the midpoint of each placement, and then one near the end for each of the placements. Just as the introductory phase, the midpoint placement isn't mandatory, but that doesn't mean that we don't strongly encourage people to do that, because what it allows you to do is to get some feedback about where you are and then to change what you do in the second half of the placement, so you can really focus on your own specific learning needs that are available in that placement.
There's quite a couple of questions around the MCR versus the MCF, and I wondered if you could potentially elaborate what the difference is. Obviously, the MCF is, as we all know, a multi-source sort of feedback in terms of coming from all sorts of people within other healthcare professionals as well. But I wondered if you could elaborate a little bit more what the difference and what you aim to achieve from both.
Well, so the MSF is inclusive of lots of other different aspects of the team. It does look, it asked the different questions that are being asked, and the what it does is be able to bring in the opinions of you know your peer levels, other supervisors that you might not have been involved within the MCR, other para specialties, consultants from other groups and specialties. It's a small number of questions that covers a breadth in relation to your practice. The MCR is really looking at structured look towards the outcomes and the capabilities that we've grouped together, and it is therefore set at sort of a developmental level to allow the feedback related to your supervision levels. So I hope that comes some way to showing that there is a large difference between the two groups. The MSF will stay and would encourage it and remains at one a year.
I've got a trainee who's asked if they're out of program in terms of what requirements do they need during their training in the out of program, and also when do they then switch to the new curriculum?
Okay, so they change the new curriculum when they come back into training. But if you're, let's say you're out of program and you're doing part of a clinical job, which my research fellows do, that of course is experience that you're having, and it's progressing towards what you need to be able to do for a day one consultant. And so, you know, your time out of program doing whatever still will count towards your development towards a day one consultant as well. So when you come back in, you change, but everything you've experienced out of program will still be available to, you know, and assessed in the SIPs and the GPCs.
If a trainee struggles to come across a critical condition during their training, how do they then get signed off, or how can they get around that?
Well, I think, well, to start with, say I think it's that's unlikely. Certainly within the our two specialties, the critical conditions have been written to things that we're mandated to know about because they're very much life and limb threatening, and they're common, and therefore you need to undertake to proceed through. If you had absolutely struggled to have seen the clinical exposure of a critical condition, then it's not unreasonable to think that you could have a discussion with your supervisor to ensure that you have the full knowledge level of it into how you would be managed. The critical conditions are also covered within the JCIE exams within the specialty as well. So you'd have been assessed in that manner as well. If it was absolutely that the people hadn't been able to progress it, I think it's really I'd reassure people I don't think they're likely to get a requirement for an extension of training through no fault of their own if they hadn't been exposed to a particular condition. John, I don't.
Yeah, so I mean, the critical conditions about knowledge, aren't they, and application of knowledge? So you should be able to do that. You know, talk about a case if you haven't actually seen it. Probably maybe the question is more about the index procedures, and so there may be, and I'm thinking particularly pediatric surgery has a lot of index procedures, and I suppose there may be a circumstance, although pediatric surgery assured us all trainees should be exposed to these, that might not be. And then I think that's a question, just flagging that up early with your trainers and the TPD and say, listen, I still haven't seen any of these, what can we do? And then perhaps being sent to, you know, have the opportunity to go to another hospital where there might be more focused exposure. Certainly we've done that in the East Midlands with some of our trainees who need certain things to get to CCT. So, you know, like most problems in training, it's quite easily addressed by identifying the problem and just talking to somebody about it who will help. Shouldn't happen much, but if it does, that would be my advice.
Sorry, and the other thing I was going to add in, Sophie, is that all of the assessment numbers really are indicative. They're based on the basis that we'd expect a trainee to be able to have undertaken and been exposed to. So there it is some give, and if you're able to show equivalence, then you should be reassured.
And I guess that sort of leads on to another question about procedures that were originally under as DOPS, such as a trust biopsy in urology, but has now become an indicative procedure. I guess if you've had DOPS previously, do they still translate? Can you use them in the next part of the curriculum?
Yep, I think so.
Sorry, look. For self-directed trainees following the CSER route, what advice have you got for them regarding the MCR and how can they organise the meetings?
So CSER, we have some, it's different, and I don't really want to go into the details on the webinar about transition to new curriculum for trainees, but there is a lot of information about CSER and the new curriculum on the JCST website on the CSER page. So whoever's asking the question, please have a look at that, and it does give specific detail about the slight changes in the MCR that will be required for CSER. Up until August 2023, if you're applying for CSER, you can choose to apply on the existing curriculum or the new 2021 curriculum, whichever suits you best. If you are applying and want an MCR, then of course you will be well supported by the people who you work with each day. So it should be quite easy for you as somebody who's in a trust grade job in a hospital applying for CSER to get somebody to do the MCR for you. So it shouldn't be too hard, but the specific details are on the JCST website.
Yeah, so to add on to that, on that site, there is a specific MCR that's written for the CSER candidates. It's written for MCR CSER, and with that, there are examples written of that, the feedback that you might want to get or be looking to get written by your supervisors. So examples of what the supervisors might want to write, and that's all available on the JCST website.
There's a couple of questions, excuse me, around getting sort of level 4 sign-offs for your PBAs. And is it enough just to have one level 4 is one question. And if you're struggling to find a trainee who will sign you off at a level 4, is there any advice or anything that you can give for trainees in that situation?
People's the different curricula have different number requirements and indications of how many PBAs they think they should show to show that your competence. Remember that they're just an indication as well. That competence will be assessed by the CIP in relation to the management of the operating theatre as a component of that. But if as a actually example, the trainee is struggling to show competence in a particular condition, and that is looking to have an effect on progress, the likelihood is that that would have been raised through the MCR process at a much earlier level than it would have become as a problem by just an outstanding missing PBA at the end of training. So those are the sort of things that will be highlighted early on, much earlier on now, and you'll be able to come up with a solution of the developmental skills necessary for you to be able to show the competence in that procedure. So turning it around, I think that will become much less of a problem than it might have been previously. I understand the ST8 group thinking if I were to change, and that's part of the discussion in relation to your TPDs. But for the other years coming through, if there is a deficit and you'll think you'll struggle to show competence in certain procedures, then you'll set a developmental plan to be able to address it at a much earlier time than would have been raised. And that's going to be the benefit of feedback and the role of self-assessment to highlight that, say, I think I'm going to struggle with this, how we're going to deal with it.
There's a question with regards to the timescale. How likely do you think it will be that trainees will actually finish early? Is it going to be quite a rare occurrence or something that will become quite common?
Well, I'm hoping it becoming more common. I mean, the indicative time to finish is exactly, apart from cardiothoracics, is exactly the same as it is now. So we expect most trainees to take about the same time. But I think as the MCR and everyone gets used to the MCR and gets better feedback, then people can focus their learning, and with the change in learning agreement, that people can focus their training a lot more closely. If feedback could be a lot better for most people, and so I think once you know where you are and you know where you're going to go, then that will help things develop a bit quicker. And we have lots of requests to bring people's CCT dates forward already. So I think that that there will be, you know, it might be the 10-20% of people who are on that, you know, everything's a normal distribution curve, isn't it? Who just pick up skills that a little bit faster, will finish that a little bit earlier, maybe by a year or so, but not have to go through the whole process of applying to do that through the SAC, etc.
I guess the alternative, if trainees need longer, is that a possibility, or is there a sort of max cap that they can have?
Yeah, so I mean, we can't just offer indefinite training to people, and so we have the indicative time, which is exactly the same as the time for each curriculum now, and then extension is through the goal guide mechanisms. So if you needed extra training time, then it can be extended a year through ARCP and then a further year at the discretion of the postgraduate dean, outside COVID. And of course, outcome 10.2 will also extend training where required during COVID. So it's all curricula sit within the goal guide and its various rules.
I think we're actually out of time, so I don't know if either of you have any of the last comments or anything else you'd like to add from any of the questions.
So I'd say thank you very much, everybody, for coming this evening, and thank you very much, Sophie, for fielding and asking all those questions. I hope it's been helpful. There is a lot more information out there. So you go to the homepage of ISCP, click on surgical curriculum at the top, everything's there. Keith's running a lot of drop-in sessions to answer any of the questions that people have. And there's also the videos on our YouTube site as well. So hopefully everything's there. It's going to feel a bit weird at first. First time we do the self-assessment, it's going to feel a bit weird for your trainers when they do it the first time. I would encourage everybody to try a self-assessment towards the end of their current placement, so that you can go into that. One, you can get used to using it before it actually counts as part of the as part of the new curriculum, but also to take it into that new learning agreement so you can hit the ground running. You say, this is where I am now. This is what my trainers think about me. Let's talk about what I can do in the next 3 to 6 months to accelerate my training.
Yeah, I would just echo that. I would just, well, the one thing, just go on the ICP and click on the trial. Have a look. It's not really scary. It's there for your benefit. As John had showed, the timeline and the amount of work that went into creating a new curriculum, they were all done with the idea of this being beneficial to the trainees and for the trainees' development. And we think that we have come up with a tool that allows that to happen, and genuinely that when it goes live in August, we immediately put you in a better place. So have a go, have a look, and if you've got any questions, just come and ask. And thank you very much for coming as well. And brilliant. Thank you very much indeed for doing all the questions, Sophie. You've got away with us threatening to ask you a question, so we haven't got time. Sorry.
Okay, well, thank you very much, everybody, and good night.
Excellent. Thank you very much, then. Cheers. Bye-bye.
Bye.